Hello and welcome to the Oath and Staff podcast. I am A. David Singh, bringing you stories from people of medicine who serve humans and animals in unique and wonderful ways. In today's show, I am talking to Dr. Sam Ebenezer Athikarisamy. Sam and I go way back to 1992 as medical students at CMC Vellore in South India. After completing his basic medical degree, Sam went on to train in pediatrics, or child health as we call it at Vellore. In 2008, Sam left for Australia and trained further in neonatology, which is a subspecialty of pediatrics. And now he takes care of newborn babies who need intensive care. His interest in global health led him to acquire a postgraduate certificate in public health from the University of Liverpool. And his latest achievement is a PhD, which he earned while working as a full time neonatologist at Perth, Western Australia. I am honored to invite Sam today on the show, where we will dive deep into his remarkable achievements, the decisions he made along his industrious career, and how his work is creating a profound impact on the health of newborns. Welcome, Sam. Welcome to Oath and Staff.
Thank you, David, and such a lively introduction. And I'm really grateful for having me on this show. And you're doing a great job by bringing out many stories. And I really enjoyed listening to all your previous podcasts. I am really looking forward to having a chat with you.
Thank you, Sam. Let's kick things off at the beginning. What got you started in medicine and later in pediatrics? Is there a story behind why you decided to become a pediatrician?
In my school days, I was not interested in becoming a doctor. I was more inclined to do something in the civil services, IAS and IPS. In fact, we had two role models in our village. So all my preparation was towards civil service exam. But my parents had a different idea. There were some few doctors in our family, but I never seen medical as an option. I remember telling my mom that it would be a waste of money and effort to go and write an entrance in Madurai, which was the closest center for me. But I'm really thankful to God and also to my parents who chose this path for me. So I would say that it was parental choice, but which I really enjoyed. Now coming to why pediatrics, during medical school, community medicine was something I was really interested, and I really enjoyed my COP and chat posting. And then in final year, I started going to pediatrics ward, and that's the time when I realized that pediatrics is something you can have a real impact. Something really caught my eye was the impact of immunizations and how much it had really changed the lives of many children. I don't know whether you know Dr. Julius Scott, who was a very inspiring teacher and who became a good friend of mine later on. He played a major role in me choosing the pediatrics. So when I finished my internship, I wanted to go to Tiruvalla for my service obligation because there was a pediatric setup, but somehow it didn't work out. When I went to Nasapur, I really enjoyed the time. I working with cardiology and general surgery. Towards the end, I started working in pediatrics. So the decision to join Vellore back, it wasn't that easy as I thought. I tried department sponsorship through cardiology because cardiology at that time was looking for a pediatrician to train in pediatrics and then later become a cardiologist, but didn't work out. So I studied pediatrics and then I wrote the special paper and I was able to get the sponsorship and do pediatrics in Vellore, which I really enjoyed, and I'm thankful to all those people who helped me along the way to get into that stream. So that's how I became a pediatrician.
I remember when you were training in pediatrics because at the same time, I was training in neurosurgery. And when we used to get consultations to come and see a child who had some intracranial problem, I remember I used to run into you quite a bit when I used to come to the pediatric wards. So our connection goes a little bit deeper than being batchmates in our MBBS days. We were also specialist trainees during the same era. So that's very nice to reminisce about old times. Now let's talk about when you left India and went to Australia to become a neonatologist. I was wondering, what is the story behind why you decided to narrow your focus from general pediatrics to a neonatologist who works in a surgical neonatal intensive care unit?
This was something which I did not plan, to be honest, and it just came on my way. I was still interested in public health. So when I finished 3 years of my service obligation in Ambajipet, it's a very small town, and even though I was a pediatrician, I was posted in a women's hospital. So that was a purely an obstetric hospital where they had about 250 to 300 deliveries, and there were no pediatrician. We had few of the nurses from Australia visiting at that time as part of the mission work, and they helped me to set up a very good level 2 nursery. So level 2 means we don't ventilate, but everything else we can take care of. Preterm babies and term babies with asphyxia and things like that. And so the interest in neonatology came only because of work in Ambajipeta. At that time, there were no DM courses in India. There were only few institutions like AIMS, and probably PGA also started around that time. Vellore didn't have the DM program yet. I still had that passion about the public health. At that time, the WHO TB consultants advertisement came. So it was a very good job to get into WHO or UNICEF. And so I applied for the job. I went to Delhi to attend the interview. But during the interview, they said, I'm too much of a clinical person. I didn't have any public health background. So they didn't offer me the job. At that time, Julius was in Australia. He got me the job in neonates in Adelaide. It all worked out in such a way that the interest I had in Ambajipeta, it helped me to gain more experience how developed countries manage their preterm babies. Once I became a neonatologist, I had a choice between a retrieval medicine or a perinatal neonatology. But I took up surgical neonatology because that's something which I was passionate about. That's how I ended up being in an ICU taking care of surgical newborns.
So you've had a long training period, which is what reaching the top of one's career usually involves. You began MBBS in 1992, and then you went on to do your MD in pediatrics, followed by neonatology in Western Australia. That's remarkable. So I was wondering that when you were going through your pediatrics training or when you were a medical student, did you have a favorite teacher or mentor? And what is the story, how they have influenced your career?
We were very fortunate and blessed to be in Vellore for our training. There were too many good teachers around to look after us. One thing I would like to highlight here is I came from a Tamil medium background, so it was a bit difficult for me to transition. I had a good number of teachers who really helped me during those times. Dr. Dayakani Selvakumar from Biochem, Dr. Kalyani Prem Kumar from physiology, who became my foster mom later on. And then in anatomy, I had Dr. Thomas Pologron as my tutor. So they're all very kind and sympathetic towards me to teach me, took extra effort to take care of me. And then a lot of credit goes to our own classmates who looked after me during those formation years. And then seniors, of course, YD and Denisa from 88 batch. And then my co-brethrens, Bobby, Charlie, and Sam and Spo. First year was really an important point in life. We were all kind of a different seeds coming from different parts of India, and we all had different requirements. Two people who really influenced my career during my undergraduate time was Dr. Bhushna Moses, who was then the principal, who was very instrumental in me staying there and who really encouraged me. And then During my post-graduation was Dr. Prabhakar Moses. We had Dr. Raghupati, Dr. Chellam Kribagaran, Dr. Jana. They're all great experts. Dr. PDM had a special influence on me because I finished my peripheral posting for a year. I hardly spent any time in child health, about probably 3 months or 4 months. And when I came back, I was expecting to do a second call for another 3 or 6 months. But on the day I joined back child health, he gave me the third call pager and said, Sam, you can do it. So if you become a third call in a unit in child health, you're almost like a consultant. If you can manage anywhere in the world. I really thank Dr. PDM for my career, and I still carry a lot of his influence in my day-to-day practice. He also showed me how to write CV, how to get testimonials. When you go abroad, what are the things you need to do? It's more of a career guidance as well. So I keep telling my close friends, the Israelites, had one Moses during their wandering, but God blessed me with two Moses. One, Dr. Bhushna Moses during my undergraduate days, and Dr. Prabhakar Moses during my postgraduate days.
Oh, that's fascinating. The point you made about having two Moses. And of course, I completely relate with you the number of people whose shoulders we have stood on to reach where we have reached.
Absolutely, yeah.
So, tell us, what does a typical day at work look like for you as a neonatologist working in an ICU?
Neonatology, we take care of newborn babies, by definition up to 28 days. But if the babies are born preterm, we take care of them till they are term equivalent. So there are three different branches. People look after preterm babies in perinatal units. These are attached to large women's hospitals. Another branch is where the neonatologists take care of the retrieval, because babies who are born in the remote places or country towns, they need to get to the referring hospital safely. So retrieval medicine, it's a subspecialty within neonatology. And then there is a third group where the neonatologists take care of babies who need surgery. We look after babies who have been diagnosed with congenital anomalies in utero, or maybe diagnoses which had come after they are born, like diaphragmatic hernias, esophageal atrasias, and malrotation. So all the surgical problems the newborns face, they need surgery in a children's hospital. The work I do, we have a surgical NICU, but we also admit complex medical issues. If there is any subspecialist input needed, endocrinologist or a cardiologist, um, they come over to us. We don't have any in-house deliveries. All our babies who come from a referral hospitals, and we take care of those babies pre-operatively and post-operatively. I remember Dr. Shalini, our classmate and friend who shared in your podcast some time ago. Their work as a pediatric surgeon bit reliant on the surgical ICU care, because it's not only the surgical skills but also how they are looked after pre-operatively and post-operatively. So our work involves, taking care of these babies who need complex surgical needs, and then we do follow up when they become 4, 8 months, and 12 months. We typically take care of them till about 1 year, and then they go to general pediatrics.
Sam, thank you for sharing that. I was not really aware of the extent of work that a neonatologist does, especially a neonatologist who works with children who need surgical care. So, thank you for sharing that with us. While you were working as a neonatologist, you went on to get your PhD at the University of Western Australia. During your doctoral studies, you had focused on retinopathy of prematurity in neonates. So, I have two questions for you. Why did you choose to do a PhD when you were already on top of your game? And secondly, why retinopathy of prematurity? Are there any stories behind the decisions you made?
David, it's quite a long story, but I want to share it. When I joined Adelaide in 2008, one of the neonatal consultants asked me, Sam, if there's one thing you want to go back and implement in India, or what would be? I immediately said ROP, screening for newborn babies. That's something which was very systematically done in Australia. The technology was coming up, a retinal camera, which we call RedCam. So that always stayed in my mind, how to have a kind of a a full surveillance for ROP screening for those babies at risk in India and low middle income countries. Interestingly, when I moved to Perth, my project, one of my colleagues suggested that I should do on RedCam. So we thought it'll be a good opportunity to explore it further. We did a systematic review, and that put a seed in my mind to study further. And also from my own experience from India, one is a lack of awareness. Second, there was no infrastructures to do ROP screening. So if you look at the ophthalmology workforce in India, they were mainly adult ophthalmologists and some subspecialists in pediatrics as well. We had very limited number of ophthalmologists who could look into babies' eyes and do a proper screening. Even in Australia or Canada, US, the number of ophthalmologists who can look into an infant's eyes and diagnose ROP and treat is very, very minimal. So we needed an alternate source of screening. And I was doing public health from University of Liverpool. At that time, there was a project for me to do a program evaluation. I didn't have any program in my mind, but I kind of hypothesized and imagined a hub and spoke model where you have one camera going to different hospitals and taking images, and somebody sitting somewhere else reading those images and giving a report. Then when I looked into the literature, we found that actually Karnataka was doing that from 2009 onwards, and as a pilot model initially, and then they were expanding to the entire state where a team would go and screen those babies in SNCU's district hospital, and ophthalmologists at Bangalore would read the image and bring those babies who need treatment. So that really caught my mind, and so I went there to study that model in Karnataka. So that kind of the background for my ROP interest. Now coming to why do a PhD in my neonatologist career, our unit was seen as an academic unit, and many of our senior colleagues had already done PhD. Even though I had the research idea and statistical support, when my supervisors approached me whether I would be interested in doing this as a PhD, I said, yeah, why not? Because it gives a lot of authority, and I did it in a very systematic way. So it was a very good opportunity. That was something I was passionate about, and we do a lot of work on that, which I'm happy to share.
Thank you for that, Sam. And now, would you please walk us through the salient features of your work in simple terms and tell us how your research has advanced our understanding of retinopathy of prematurity?
David, first of all, I want to say I wanted to get into the community rather than going into a bench top or a molecular research or what causes ROP, because there is almost 80 years of research what causes ROP, and we all know that oxygen plays a major role when the babies are born preterm. Their vessels are very immature, and when they are exposed to high oxygen, there is an arrest of vascular growth. And when the retina becomes hypoxic, there is a neovascularization. So basically, abnormal blood vessel growth in the retina of these newborn babies pulls the retina. So they have a retinal detachment and they go blind if it's not treated at the right time. So my research was mainly about how we can prevent those babies going blind in low resource settings by having a screening model which is appropriate for the setting. What is available and doable in Perth may not be applicable in Bihar or in Tamil Nadu. So what is the appropriate screening model for contextual settings? That's what my PhD was about. We had two different models, one for high resource settings and one for low resource settings. In setups like us, where we have extreme preterm babies, those who are born around 24, 25 weeks, who are still on ventilator or who may be still needing high requirement in ICU, where the technicians may not be able to handle those babies. So we thought the best model would be to train our neonatal nurses to take the images. So we were able to implement a nurse screening model, and that is one highlight of this thesis, that we tested the model in our setup, and it was as good as the ophthalmologist, and they were able to pick up all those babies who need treatment. That is the final outcome. In low resource settings, our work focused on validating the existing programs and seeing that they are doing an excellent job. So I might just mention here that the Karnataka model faced some challenges because the government wanted to go back to the ophthalmologist model at one point of time. So we went and evaluated the program and gave the report. It's more of an advocacy saying that what the government and the private partner is doing an excellent job. So that report was submitted to the government in 2015, and so now that being replicated in Maharashtra, Gujarat. It's our aim and vision is that India should have national wide screening. And the third part of our thesis was to communicate this effectively to the policymakers, the doctors, because the lack of awareness is still a bit of a concern. They always thought it was a disease of Western countries. So as the neonatal care advances, the more premature babies survive. The more premature babies survive, we know that there is more babies at risk of ROP. And if they don't get screened, some of them are going to go blind. So neonatal care doesn't finish with babies getting discharged from NICU, and it finishes only when their screening for ROP is also completed. We wanted to communicate this finding in an effective way. So we wrote a policy paper, and it was published in Lancet Regional Health, where we compared the burden of ROP with polio, because that is something everybody was familiar in India. We had so much of awareness, and the pulse polio program, every baby was immunized, and we were able to eradicate polio completely from India. So we wanted to use that as a model to, tell the policymakers and the health providers that if we can do that for polio, we can do it for ROP, because the impact of ROP is worse than polio.
Retinopathy of prematurity or ROP affects the eyes of preterm infants, and without timely screening and treatment, it can cause lifelong blindness. Worldwide, the number of babies needing screening is increasing, but the number of ophthalmologists isn't. That gap highlighted the need for new scalable solutions, and that became the focus of this research. The research first examined whether simple bedside measures like postnatal weight gain could help identify high-risk infants early. This included validating the WinROP algorithm in an Australian cohort and reviewing the global evidence through a systematic review and meta-analysis on weight-based prediction models. Next, we explored how to widen access to screening. We assessed whether neonatal nurses using wide-field retinal imaging could reliably identify infants needing treatment, and we also evaluated the emerging evidence on artificial intelligence as a diagnostic support tool. A major component focused on low and middle income countries where the burden of ROP is rising rapidly. We examined what a practical, scalable screening model could look like in resource-limited settings. Finally, the research drew lessons from India's success in the Global Polio Eradication Initiative. Polio eradication showed that India could reach every child, even in remote and marginalized communities, and many of those same principles could guide efforts to prevent ROP-related blindness. Ultimately, the research aimed to ease pressure on ophthalmologists, strengthen screening pathways, and help ensure that every preterm baby, wherever they are born, has the best possible chance to see.
What you have described in a few minutes' time is a remarkable undertaking. It's very impressive. Thank you for having the strength and the dedication to do the work that you're doing. In the coming years, what do you see as the key challenges in preventing retinopathy of prematurity and blindness in preterm infants?
It is a question which everybody needs to think. Everybody working in neonatology and ophthalmology, and even the policymakers and the government, because as we progress with our medical advancement, the preterm babies who are surviving in the lower gestational age also has increased, and it's really great nursing care and neonatal care. Babies who are born at 22, 23 weeks are also surviving. That's almost 18 weeks born prematurely. And these babies, the incidence of ROP is very, very high. And in the future, there is not going to be enough workforce for the number of babies who need this screening. So we need to really train the workforce who are able to screen these babies and interpret images, and also treat those babies who are in need of this treatment. And there's a lot of things has evolved in the last 20 years in terms of treatment. Previously, laser used to be the treatment of choice. Now they developed something called aggressive ROP, where the zone 1 is involved, which is posterior most part of the retina, close to optic nerve. So you can't laser because they end up with a lot of sequelae. So anti-VEGF is a drug which is given in the vitreous, which is the first line of treatment. So we need workforce who can give those treatment. There are two different kind of problems we are seeing. In high-income countries, extreme preterm, the survival rate is high, so they need screening. And when you take the low middle income countries, the preterm babies who are born 28 to 32 weeks, previously they were dying because there were not enough SNCUs to take care of them. But the NICU has kind of evolved, and they have more facilities to take care of these newborn babies. And in these units, in low middle income countries, there is no strict oxygen control. Those babies are at higher risk. So we have a two different population. And one is that extreme preterm babies who get the disease because of the nature of the retina development. And then you have a different group of babies who develop ROP because of oxygen management. So we need to look at the primary prevention to reduce the incidence of ROP. That should be our primary goal. Meantime, if you can imagine the number of babies who are born in low middle income countries, the sub-Saharan Africa and India, Indonesia, a few of the South American countries, the number is huge. The AI has come in, artificial intelligence come in. There are a lot of studies which has been done show that they pick up the ROP in a very systematic way, and also the accuracy is 98 to 99%. We need people to do the imaging. Unless somebody does the image and send it to a reading center or AI setup. So we need a workforce to kind of match that amount of work. So that is the challenge we are facing in the next probably 10, 20 years.
Thank you for sharing those insights, Sam. And now let's shift gears a little bit. Tell us, what activities do you do for leisure to balance your hectic life as a neonatologist?
I do have a very limited number of leisure activities. I do spend a lot of time with family, my wife and daughter, and we go for drives, long drives. And the Indian Ocean is just about 6 kilometers away from us. If we feel homesick, we can say that we have gone to the Indian Ocean and come back. Beautiful beaches here, and Western Australia has got one of the best beaches, and the sunset is really amazing. So that's something we really do as a family. And cricket is something I really enjoyed right from childhood. Kapil used to be my hero at that time. Two reasons. One, he came from an agricultural background just like me. And second is, he was also a brand ambassador for the Rapidex English course, which I used to be a big fan in my high school days. I followed the Indian cricket team here when they came in 2011. So wherever they went, we went and watched the cricket. In fact, in 2018, I wrote umpiring exam because I was so much into cricket. Then I realized that it's too much of time commitment needed. I came out of that. But it gave me a lot of interesting lessons, how to be decision maker. And one thing I really learned, which may be useful for our viewers, every time you make a decision, see what is available in front of you rather than what you did before. So that's very true for your life and as well as for your clinical career. Then other thing I really like is I like reading early church history. and Apostle Paul is someone I really admired for his writing. I have huge collection of his books, his biography. One day when I get time, I would like to put everything together as a summary. So that's something I really enjoy.
It was wonderful listening to these personal anecdotes. And even though we do things outside our medical and professional fields, I feel that every extracurricular activity adds different facets to us as human beings. Personally, for me, I am very grateful that you decided to become a doctor and not an umpire, because the impact that you have on preterm babies through the work and research you're doing is tremendous. So these are the kind of insights people need to see, the more human side of the people who are top notch professionals, that they have got other dimensions, other facets. How do they make their decisions? So thanks for sharing that with us. Now, talking about neonatology, what's the one thing you'd like to change about how neonatology is practiced or how neonatology is taught?
A lot of shift has gone towards simulation-based training, but I think we still need to focus on our clinical skills and spend more time in the clinical space. The neonatal advanced training in most part of the world, including India, US, Australia, is 3 years after the general pediatrics training, which is not really adequate. And in the US is thinking of changing to 4 years, but we can't stretch the training any further. So one way of doing that would be to start the advanced training early in their pediatrics training. That is something it's still being considered in many places. And the second thing, there is a lot of gap between the LMIC and high income setups in terms of survival of preterm babies, and that gap needs to be reduced. And for that, a lot of support needed from the bigger organizations like WHO, UNICEF. When they set up the NICUs, SNCUs in the low middle income countries, I mean, they need to make sure that there is a full setup. What I mean is, if there is a new neonatal unit is being established in Canada or Australia, they would make sure that there is adequate resources for follow-up as well. Whereas in low middle income countries, there is no adequate support for follow-up. We want the babies who survive have a quality of life which is meaningful and also less burden to the family, to the society. So we have the duty as a neonatologist or a policy maker to make sure that whatever we are delivering is of the highest quality.
Sam, as you might know, the Oath and Staff podcast is listened to by doctors from various specialties, but also by medical students and their parents. So I was wondering if you have any advice that you'd like to give to medical students and to pediatrics trainees who are considering neonatology as their career.
There is an inherent fear that neonatology is tough. And I had that fear when I was doing MD pediatrics because we had long duty hours. We never saw the sunset or sunrise. And you can relate to that as well, David. And we literally lived inside the nurseries. But things have changed. I hear that many setups working hours have reduced. So I think neonatology is not tough. That fear has to go off from one's mind. And there is a great reward. You are helping that family to transition from a very difficult situation to a new phase. A lot of pediatric trainees take that as a second fellowship. They become a pediatrician, but they subspecialize in neonatology so that they can take care of the preterm babies. There are limited jobs as neonatologists, but there will be a huge need in the future. So if you are really passionate about it, you should pursue it.
Sam, it was so wonderful speaking with you. Many thanks for coming on the Oath and Staff podcast. I had a great time getting to know what you've been up to since leaving CMC Vellore, and I'm in awe of the incredible clinical work and research you are doing in the service of newborn babies. Thank you.
Thank you, David. And you are doing an amazing job bringing out unique stories. All the guests you had in your podcast, I know them. After listening to your podcast, I could see a different perspective of them. So I'm really glad you are doing this amazing job. And I wish all the best in your journey. Thank you.
And that's all for today, folks. I hope you enjoyed this episode with Dr. Sam Ebenezer Athikarisamy and also found it inspiring. Thanks for tuning in and subscribe for more.